Today, we will share our analysis of Charles et al.'s 1999 Models of Treatment Decision-Making Framework using Walker and Avant's procedure for theory analysis. This theory originated in McMaster University in Ontario, Canada. In the 1990s, a shift in academic discourse critiqued paternalism, especially the idea that physicians, rather than patients, were in the best position to evaluate the benefits and risks of treatments. At the same time, legislation reinforced the rights of patients to participate in decision-making. This conceptual framework was an evolution of Charles et al.'s 1997 model, which sought to provide conceptual clarity to the concept of shared decision-making, an alternative to paternalism. The authors revised their original model after considering the results of a 1998 study on patients with breast cancer. Their updated framework accounts for the dynamic relationship between decision-making approaches and the analytical stages of decision-making. Charles et al.'s framework borrows from Emanuel and Emanuel's model of patient-physician interactions. Charles et al.'s own 1998 interpretive model on information transfer between physicians and patients underlies their 1999 framework. The authors created this information transfer model in response to their study on patients with breast cancer, and this model will be touched on later in the presentation. Limitations regarding the origins of the models of treatment decision-making framework include that the authors did not identify their disciplinary backgrounds or whether they used a systematic approach to inform their model. Let's consider meaning. The authors specify that their 1999 framework is for clinical contexts where a patient with a life-threatening disease has several treatment options, all of which may have various benefits and risks. The authors define several concepts. Treatment decision-making is a complex process that takes place over time and can involve many individuals. There are also three analytical stages of decision-making. The first, information exchange, refers to the type and amount of information exchanged between the physician and patient. Deliberation is the process of expressing and discussing treatment preferences, while deciding is that final task of decision-making where treatment is chosen. There are also three treatment decision-making approaches and undefined in-between approaches. In the paternalistic approach, the flow of information is largely one way from the physician to the patient. The physician, who shares the minimum amount of medical information legally required with the patient, deliberates alone or with other physicians before deciding on the treatment themselves. In the shared decision-making approach, the flow of information is two-way between the physician and patient. All relevant medical information from the physician and personal knowledge from the patient are shared. The physician, patient, as well as relevant family, friends, or other physicians are included in the deliberation process before the physician and patient decide on a treatment decision. Finally, in the informed approach, the flow of medical information is largely one way from the physician to the patient. Only the patient and their significant others deliberate before the patient makes the final decision alone, though. The relationship between analytical stages is linear but not necessarily unidirectional, while the relationship between decision-making approaches is dynamic. That is, approaches may change depending on patient preferences and needs. Shared decision-making assumes that both the physician and patient have an investment in the treatment decision, perceive there are choices, and are willing to engage in decision-making. The overall model assumes a dynamic relationship between decision-making approaches, and that there are no good or bad approaches. One of the framework's strengths concerning its meaning is that most concepts and the relationships between them are clearly defined, with the exception of life-threatening illnesses. Unfortunately, however, the authors do not consider the role of significant others outside of the deliberation stage. A strength of the framework is its logical structure between concepts and its ability to make predictions, including about the behaviors of physicians and patients using different approaches, and the analytical stages they'll engage in. Unfortunately, however, the theory has logical fallacies. For example, the authors argue that decision-making does not occur within the microsystem of the physician-patient dyad. However, they do not include interprofessional team members in the framework, nor do they include significant others outside of the deliberation process. Furthermore, while the authors argue that there is no good or bad treatment decision-making approach, they focus much of their discussion on the limitations of paternalistic and informed approaches.
This framework is a middle-range theory because it has a narrow scope focused on the single phenomenon of treatment decision-making occurring in a specific context. It also has a wide breadth because it discusses why and how treatment decision-making will play out based on the decision model that the patient and the physician chooses. Lastly, it is a middle explanatory theory because it prescribes how concepts in the framework are related. The strength regarding generalizability is that it uses three well-known models. In fact, both the original 1997 model and this current conceptual conceptual framework has been highly referenced according to Google Scholar. Further, the framework was applied by others in pediatric care, primary care, and decisions related to chronic diseases and end-of-life care. Moreover, the authors have noted how power imbalance and the lack of time can make certain models less applicable. For example, contexts where physicians monopolize power would be ideal for a paternalistic model, but would be counterproductive for an informed model, where the patient is the central decision maker. A limitation is the fact that the article did not explicitly state whether the conceptual framework can be transferred to other clinical contexts. But based on the components of the framework, it inherently ignores, for example, social decisions and patients who do not have the capacity to communicate or understand language or information effectively. Parsimony. There are 10 concepts and variables in the conceptual framework, 4 decision-making models, 3 analytical stages, and 3 possible participants in decision-making. The framework is presented simply and succinctly and use clear language for the most part. The limitations include the following. The word model is inconsistently used to describe treatment decision-making approaches, while sometimes it refers to the whole framework, which can cause confusion. There is also a lack of a conceptual diagram. Moreover, it does not completely explain the phenomenon. For example, applicability to an interprofessional approach is limited because it was not mentioned. It does not explicitly mention decisional conflict, evaluation of decision, and decision quality. Some of these concepts are obviously newer than the framework. However, the presence and importance of these concepts can be extrapolated from the qualitative study that informed the framework, where their participants expressed a sense of blame and fear of making the wrong decision. This internal conflict resonates with the nursing diagnosis of decisional conflict and posits the need for evaluating the quality and how certain these women are of their decisions. The strength of the conceptual framework, according to testability, is that it is supported by a qualitative study. Specifically, it was an exploratory descriptive case study done to explore the experiences of 20 women with early-stage breast cancer regarding decision-making through open-ended individual interviews. Key findings include how patient can both interpret risk based on reported probabilistic chance of treatment efficacy, but they can also use their experience, values, and beliefs to create an understanding of the information they receive. Lastly, the participants reported that they acknowledged the physician's technical knowledge, hence preferring shared decision-making. Yet some women still reported wanting to make the decision on their own. Furthermore, based on the conceptual framework's predictions, some hypotheses can be generated. Hypotheses related to the dynamic process of treatment decision-making are not testable because of the difficulty in pinpointing when one should end and when the other should begin in practice. Empirically tested hypotheses relate to the monetary and temporal costs of each model and the effectiveness of decision aids in respect to a decision-making stage. The limitations to the conceptual framework's accessibility are that an intervention was not evaluated as part of the conceptual framework's testing, nor was face and content validity demonstrated. There were also no tools provided or referenced in the conceptual framework. The explicit strengths of the framework relates to its utility to educate physicians, medical students, and patients about decision-making. It can also be used as a tool to help express physician or patient's preferences in decision-making. The framework also provides more options for patients and physicians and permits flexibility in either mixing approaches or changing approach within or in subsequent patient-physician interactions. Lastly, the stratification of treatment decision-making into stages allows for specific assessment of decision aids and costs in relation to a specific stage. While we have discussed limitations throughout this presentation, the authors did not specify the limitations of their own model.
To assess relevance to nursing, Fawcett's meta-paradigm is applied to this framework. In this framework, patients are persons with life-threatening diseases who have various backgrounds and values influencing their interpretation of information and risks. The authors offer a detailed discussion of the environment of treatment decision-making. For example, they note that the place of the patient-physician encounter may influence the patient's level of comfort and their ability to establish trust with the physician. While the authors do not give an explicit definition of health, they do acknowledge that different treatment options will have different impacts on the patient's physical and psychological well-being. The theory makes no reference to nurses, and this may relate to the fact that nurse practitioners did not gain legal authority to independently diagnose and prescribe in Ontario until 1993. Advanced practice nurses, however, may have roles that emulate that of the physician in this model. For example, like physicians, nurse practitioners can act as bearers of medical information and, as prescribers, they also have the power to ultimately accept or reject treatment decisions. We hope to see you in the discussion board to share your thoughts on these questions.